As you know, I'm a pediatric gastroenterologist. I work at Yale University, which is a very reputed university. I've been working there for 10, 11 years. And I run the pediatric IBD program, so that's the area of my interest, where I do the clinic and I take care of these children. And in the past few years, I have also been interested in seeing more and more obese kids in our pediatric GI clinic. And you know, we've been wondering about how that affects their gastrointestinal problem. So we have been looking at that, and I'm going to share some of our work with you. So this is a Yale New Haven, where did this go? Yeah, this is a Yale New Haven Medical Center where I work. I know there are a lot of international candidates here, so I just put a map of the United States. So we are on the East Coast. This is where we are, Philadelphia. Then there's a New York City, and then there's this New Haven, which is, it's not a big city, but it's a decent sized town. That's where the Yale University is there. This is East Coast, this is West Coast. So you get the idea of the geography. So the objectives of my talk are, first I'm going to talk about obesity and why we all as a healthcare provider, whether you're a physician, nutrition, nurse, we all have to tackle this big problem of obesity. And it's not just problem in the United States or Western Europe, and it's definitely not restricted to developed countries only. It's going to be a problem all over, and it worries me a lot because it's going to take a lot of our healthcare expenses. It's going to cause a lot of healthcare burden. So I'm going to talk a little bit about that. And what I'm going to talk about is also connection of obesity and gastrointestinal disorders that our group has been working in last few years. Secondly, then I'm going to talk about inflammatory bowel disease. I know we have a really diverse background of collection of people, so I'm going to give you more information about inflammatory bowel disease, the diagnosis and therapy. And finally, I'm going to connect the dots. I'm going to connect how obesity and inflammatory bowel disease are related, the question whether they are related or just a spurious association, what are the prevalences, what is the potential mechanism, and finally, most important, what's the clinical effect or clinical significance of these. So first, the CDC definition for children. CDC is Center for Disease Control. That's in Atlanta here, which gives us the definition and which states which puts the health standards for everything. So for children, it's the overweight is more than 85th percentile for body mass index. So body mass index is calculated by weight in kilograms divided by height in meters squared. And we calculate body mass index for age and gender. So you know, for boys it's different, girls is different, and different ages is different. So if the child's BMI is over 85th percentile, it's overweight. And if it's more than 95th percentile, the child is called obese. In adults, usually they use different definition because most adults are already grown up. So they usually use a specific point, like usually BMI more than 30 is considered to be obese. Although some studies like to use BMI 35. There are also in the literature of obesity, people use different degrees of obesity. And we have also used that because somebody who's just above 95th percentile and somebody is like way above 95th percentile, you want to make some distinction between them. And for that, we usually use BMI Z-square, where you can assess sort of more severe degree of obesity. This is a map of the world. It's from the World Health Organization. It talks about the percentage of obese adults worldwide. So here, the obese adult is defined as body mass index equal to or greater than 30. So this is a very interesting graph, and very scary graph. We do not have a great data from the areas which are gray, like some of the African countries and some of the Russian countries. And if you look at the color coding of the key, here yellow and orange are around 5 to 20% of patients being obese. And you can see India, China, I think even Philippines probably here somewhere, is showing that there are 10 to 20% of patients or people are considered obese. If you look at other areas like Eastern Europe and other things, the percentage rises to 30 to 40%, same in Latin America. And the dark bright red is where the obesity percentage is 50th percentile. So that's 1 in 2 persons. It has BMI more than 30. So that's a huge problem. And as you can see, US and Canada leads it. There's a problem in England, Western Europe, Australia. So these countries, the developed countries, are obviously leading. There's a lot of obesity there. But even developing countries are not far behind. They're catching up. And why this is happening is because our lifestyle is changing. You know, we all have more physical, less of physical activity. And the food has become relatively inexpensive. We are getting more prosperous. There's a more middle class or growing middle class in every country, like India, my home country. You can see there's more prosperity. The food is easily available. People are doing less and less physical activity, and this is just catching up. And the whole world is getting more obese. So if you look at the view from space in 1970, this is how Earth looked from the international, nice and round. But if you look at recently, now it's looking like this. There's a nice big middle bulge there. You see that? So this is a problem for all of us, for every healthcare provider in every country on this planet. How about children? A simple statistics, in 1970, there were 5% of children who were considered to be obese in 1980 I meant, which is not far, like just 30 years back. And now it's around 17%, so it's tripled, more than tripled. And if you take percentage of children who are overweight, and children who are overweight and obese, that's 1 in 3 children. So 1 in 3 children in this country, United States, is considered overweight or obese. So I hope you get the magnitude of the problem that we all are facing, and soon almost everybody in the world is facing. There's a similar rising prevalence of obesity in kids all around the world, in developing countries too. And we know there are certain diseases associated with obesity, like diabetes, hypertension, metabolic syndrome, and fatty liver, and those have been very, very well described. There's a plenty of literature talking about this in pediatric endocrine, in pediatric hepatology, in cardiology. But then gastrointestinal disorders was not much mentioned here. And last few years, our group, me and my colleague, in fact, she might be talking tomorrow about sort of similar issue because it's been our area of focus in last few years, about obesity and gastrointestinal disorders. As you can see, this is what the Time magazine covered for as a big problem. So different gastrointestinal disorders we see is gastroesophageal reflux. As you know, it's a relaxation of lower esophageal sphincter that allows the gastric contents to move up, and it can manifest as vomiting, regurgitation, heartburn, epigastric pain, sometimes like hematemesis. Then there are functional gastrointestinal disorders like constipation and irritable bowel syndrome. I think Iyad's going to talk about this late in the morning. And then there's organic gastrointestinal disorders like celiac disease and inflammatory disease. So anybody who practices pediatric gastroenterology, I mean, this is what our practice is, most of it. It's gastroesophageal reflux, constipation, irritable bowel syndrome, and celiac disease and inflammatory bowel disease. So I'm going to talk to you about how obesity is related to this. So we did this study in Connecticut a few years back because, as I mentioned to you, in our clinic there were so many obese children coming, and we thought at one point we estimated that half of the children in our pediatric GI clinic were obese, and we were wondering why this is happening, why do they have more prevalence of gastrointestinal disorders, and we sought to look at that in systematic manner. So the first aim was to look at the gastroesophageal reflux. So we looked at the children from obesity clinic and children from primary care clinic, and we gave them a validated questionnaire asking for gastroesophageal reflux symptoms. So we asked about heartburn, regurgitation, epigastric pain, vomiting. We also asked about did they have any recent illness that would that would perhaps present these symptoms, and if they had recent illness, we excluded them. We also excluded children who have, say, neurological problems or known metabolic problems. So these were all healthy children. Some of them were obese and some of them were controlled, but they did not have any other problems that would explain their gastroesophageal reflux. So we had a good sample of 236 obese children and 101 control. We defined obesity as standard definition, BMI more than 95th centile. But again, in the obesity clinic, we found that there are many children who were quite obese, and we defined them into a different group called severe obesity, where the BMI was more than 2 z-square point higher. We looked at two main symptoms, heartburn and regurgitation, and we also looked at the reflux score. So this is our first result. So you look at the two symptoms, we looked at heartburn and regurgitation, and this is percentage of children who have this problem. So these small bars are the control group. These are children with normal weight. As you can see, they have around 2 to 4% of children in control group have these symptoms of heartburn and regurgitation. If you look at the obese children, the percentage rises and it's like 13% or 9%, definitely significantly higher than the control group. But in these black bars, which are children who are severely obese, I think there are around 40 children who are severely obese. As you can see, the symptom prevalence is much higher. The heartburn and regurgitation is much, much higher. In fact, 1 in 4 children who are severely obese have a problem with heartburn and regurgitation. In other way, in this validated questionnaire, we could calculate the reflux symptom score. So that means you combine all the symptoms like heartburn, regurgitation, epigastric pain, vomiting, cough, and come up with a score, and a specific positive score. And when we did that, again we found a similar pattern. This was children who had positive symptom score, and we looked at 101 control. They have around 2%, very small percent. If you look at 196 obese children, around 12%, definitely significant than the control group. But we had, as we said, we had 40 kids who were severely obese, and they had 20% of them had positive reflux symptom score. So not only we showed that obesity is related to gastroesophageal reflux, but we also showed that as obesity or the BMI increases, more children are going to have reflux problems. So what's the reason for that? I mean, there are many adult studies which have been looked into this, and the main mechanism is the presence of fat in, subcutaneous fat in the abdomen, which compresses on the stomach and causes the gastroesophageal reflux. So that's been a major problem in adults too. In fact, in adults it's very well documented in much larger sample studies. Next, we looked at the functional gastrointestinal disorder, constipation and irritable bowel syndrome. This was done a few years back when I was at the University of Iowa. We looked at this time we looked at slightly different way. We looked at the children with constipation and saw are these children more obese. So a little different way of looking at the same problem. We went to the primary care clinic and we had again a big sample, and we did this retrospective chart review. We looked at 719 children with functional constipation, and we had age and gender matched 930 controls. So really good sample size. Again, obesity was BMI more than 95th percentile. And we found that in children with constipation, 22%, 1 in 5, more than 1 in 5 children were likely to be obese, as opposed to control group, which was only half of them. So definitely there's something going on here, and we thought there was a connection. We tried to differentiate them between different age and gender. So on the left, this is for the boys, right is for the girls. This is the percentage of children who have BMI more than 95th percentile. That means percent of children who are obese. So we defined the age group as 4 to 8, 8 to 12, and 12 to 18. So 3 different age groups. The white bar are boys with constipation, and the dark black bars is the control group who has no constipation. So as you can see, in all different age groups, the children with constipation or the boys with constipation are much more likely to be obese, and this was absolutely statistically significant. So definitely it happens that the children who have constipation are also more likely to be obese as opposed to control group. When we looked at the girls, except for younger girls, that time there was no statistical significance, but in other age group, girls 8 to 12, 12 to 18, there's definitely high percentage of obesity in girls who had constipation problem. Now what's the theory behind this? So probably we don't know, we wanted to investigate, but we don't have a clear evidence, but probably the unifying hypothesis is probably the diet. You would think that obese children eat more high fat and high carb diet and low fiber diet, and that probably predisposes them to constipation. So it's probably likely that the diet is a main, or nutrition is the main problem of causing these two conditions being together. We recently did a study in Connecticut, sort of looking at for irritable bowel syndrome. We looked at 450 children, again a prospective questionnaire study. We used the Rome 3 criteria for constipation and IBS. And again, we found similar, that constipation was more common in obese children, again almost 23% versus 14%. And the IBS was more common in obese children compared to normal weight children. Next, we looked at the organic GI disorders, and we were still a little hesitant to go there, because you can understand, yes, obesity is associated with reflux, constipation, irritable bowel syndrome. But when you think of organic gastrointestinal disorders, we are thinking of something wrong with the wrong with the gastrointestinal tract. And when something goes wrong with the gastrointestinal tract, the main function of the gastrointestinal tract is absorption of nutrients. You would think that will not cause problem with obesity. In fact, it will cause other way problem. As you know, celiac disease is a gluten allergy and is classically diagnosed by duodenitis or duodenal villus atrophy. And the inflammatory bowel disease, which is Crohn's disease and colitis. So usually these are classically, historically associated with malabsorption, weight loss, and growth failure. Particularly if you remember, if you look at the celiac disease textbook picture, it's classically malnourished child with very loss of subcutaneous fat, protuberant belly, and very little subcutaneous fat or muscle mass. But once we found, to our surprise, when we did a review of literature recently on this and published a review in Journal of Pediatric Gastroenterology, we looked at different studies that will address this question of obesity and celiac disease. So most of them are from Italy or USA, and they all have a good sample, around 100 to 150. And the first column looks at underweight at presentation. Second column looks at overweight or obese at presentation. And the third column looks at after celiac disease, the treatment for celiac disease, gluten-free diet. And once you do that, you want to know what happens to a child's nutrition. And that's what discusses the third column. So I want you to consider on the first column, as you can see, underweight at presentation. So you see a different percentage, around 9 to 16% of children are underweight when they get diagnosed. Like Iyad mentioned, failure to thrive. That's one of the common things that we think. When the child has failure to thrive, think of celiac disease. So it happened in 9 to 16% of these countries, again, sort of developed countries, Italy and USA. But what was more fascinating is how many of these children were overweight and obese at the time of presentation. And you'll be surprised, it's almost similar percentage, 5 to 19%. So almost similar percentage of children are obese or overweight when they get diagnosed celiac disease. So that was a little eye-opener. That means even when children are obese or overweight, you still need to think of celiac disease, because that's still a possibility. The interesting question is what happens when you put them on gluten-free diet, and that really changes. I think a couple of studies show their increase in the BMI, and a couple of studies show decrease in the BMI. And again, depends on, once you exclude gluten-free diet, are they eating too much of other non-gluten diet, and that could be that's why we are getting the conflicting results. Next, we're talking about obesity and inflammatory bowel disease, and I'm coming to changing gears and talking about Crohn's disease and ulcerative colitis. So I'm going to talk a little bit about epidemiology. So because as we saw, the obesity epidemiology keeps on rising, or the prevalence of obesity. So when do these children get diagnosed in inflammatory bowel disease? So this is a very classical graph. It's some time back, but I really like this because it explains to you. So inflammatory bowel disease is a lifelong disease. Once you get a disease, at least, as we say today, it's going to be lifelong. Maybe, who knows, in 5-10 years, we might have a great therapy which will just abolish this disease. So it can get, as you can see, the peak of diagnosis is around 19 years. But even at age of 60, 70, people can still get diagnosed with inflammatory bowel disease. But if you can see, more than half, almost more than a quarter of this patient gets diagnosed in the pediatric age group. So it's pretty important that we diagnose them because they're going to have this disease for lifelong, and this is at least half of this peak falls into the pediatric age. What we are noticing is that pediatric IBD is getting younger. We notice that children are getting diagnosed we initially thought the most children get diagnosed around 10, 12, but now we are saying children getting diagnosed at 7, 8, 3 years, 4 years, even there's something called very early onset IBD where children can get diagnosed in infancy. So we are thinking of more and more. So there's definitely a rise in the rise in the IBD. So estimated million people in the United States have IBD, and 7 to 10 children out of 100,000 will develop IBD at any given year. How do we diagnose IBD? I know people here from a different background, so I'm going to talk a little bit about inflammatory bowel disease. Children present to us either acute time course or chronic time course. So they may present to us within few weeks, or sometimes it's many months. It depends on which area of the gastrointestinal tract gets affected. In Crohn's disease, if you have a colonic disease, it causes diarrhea, bloody diarrhea, and the parents are quickly to come to your attention when it happens only in few days. On the other hand, you can have abdominal pain which is just lingering on and off, and that's been going on sometimes for a year, or sometimes 18 months or so. If it's non-specific and it doesn't cause any dramatic diarrhea, then these children come quite late. So abdominal pain can be diffuse periumbilical pain or right lower quadrant pain, because that's what the area usually gets affected. Diarrhea, as I mentioned, if you have diarrhea and bloody stools, particularly if you have a colonic involvement, then you can have really bloody diarrhea, and that can be pretty dramatic. Classically, we always say Crohn's disease causes weight loss, particularly if you have a small bowel disease, because these children don't eat well, and also they are losing nutrients through colon. So Crohn's disease can affect anywhere from mouth to the bottom, so it can present as mouth ulcers, it can present as anal problems or perianal lesion, but any part of the gastrointestinal tract can get affected. Ulcerative colitis usually presents acutely because, as I said, the colonic involvement causes diarrhea, blood in the stool, nocturnal stool. So parents are quickly to bring the child to your attention, and then obviously when you do the appropriate workup, you're going to get the diagnosis. So usually this presents in few days to few weeks history, but Crohn's disease can take sometimes many months before it gets diagnosed. So classically, the nocturnal diarrhea is very important. Usually most kids with gastrointestinal infection or other types of diarrhea would not get nocturnal diarrhea, but usually when you have colitis, this is a very cardinal feature. So how do we diagnose this? We obviously have to rule out infection. Although in United States, the GI infections are much uncommon compared to other countries, except for one, perhaps Clostridium difficile infection can actually cause colitis and bloody diarrhea. But again, that's much less common. Then we do the labs. We look for hemoglobin like anemia. We look for raised inflammatory marker like CRP, erythrocyte sedimentation rate. That gives us a good diagnostic clue. And the next one we do is endoscopy. We do the upper endoscopy, colonoscopy to assess upper GI tract and the colonic disease. And then we do the MR enterography to look at the small bowel imaging because we want to investigate the whole GI tract. And then we classify the disease as Crohn's disease or ulcerative colitis. So these are some of the pictures of colonoscopy, if some of you may be familiar with this. So this is normal looking colon. It shows light pink mucosa like inside our mouth. And these are the normal vascular pattern. It looks tortuous, and these are the normal folds, which is everything, all the architecture is preserved. So this is what the normal colon looks like. This is, on the other hand, ulcerative colitis. As you can see, you do not see the normal vascular pattern, and the anatomy and the architecture is disturbed. There's loss of vascular pattern, there's granularity, exudate, and it looks like there's a continuous and superficial involvement. So ulcerative colitis involves only mucosa and the superficial layer, as opposed to Crohn's disease, which can go deeper. It can affect submucosa, it can affect muscularis mucosa. And in ulcerative colitis, usually there's no ileal involvement. And this is a classical of Crohn's disease, where even in one snapshot, one picture, you can see this is like a patchy disease. There's sometimes here it looks bad, here it looks okay. There's a cobblestoning or segmental distribution. There's often ileal involvement, and then sometimes there's deep fissuring. And the classical histological feature is presence of granuloma on biopsy. So how do we treat IBD? And I think it's a little important, because when eventually we connect the dots, effect of obesity on IBD, we need to come back to therapeutics a little bit. So we usually use nutrition. We give them a good nutrition because many of them have weight loss. We give, there's a therapy called elemental nutrition, which is much more popular in Europe than United States, where we put the children on elemental nutrition diet and not give him any table food. And that seems to work pretty well. In fact, it's as good as steroids. And actually some of it I'm going to talk late afternoon session. Then we have medications like mesalamine or immunosuppressant like 6-MP methotrexate, and then we have biologics, which are anti-tumor necrosis factor. Then there is a surgery where we have colectomy. Colectomy for ulcerative colitis is curative, but for Crohn's disease it is not, because Crohn's disease, as I say, it can affect any part of the gastrointestinal tract. So therefore, to cut is not to cure, and therefore surgery is used very limited role or conservatively. So normally inflammatory bowel disease causes growth failure. And why is that? There are multiple causes. As you can see, children with inflammatory bowel disease have increased needs because they have to fight inflammation. They do not eat much, and this is partly because of tumor necrosis factor, which is a inflammatory markers, and when it's in the blood, it kind of has an anorexic effect. So the children don't eat well. They have increased GI losses because of ongoing diarrhea and protein losing enteropathy. If they have a small bowel disease, the inflammation or destruction of small bowel mucosa can cause malabsorption, and all this leads to malnutrition, which leads to growth failure like a vertical growth. These all can cause weight loss, and this can cause a height problem. Additionally, chronic inflammation can itself known to cause pubertal delay, and inflammation has directly effect on growth failure and growth hormones. And if we use too much of steroids, that's also going to cause problem. So as I say, in most of the inflammatory bowel disease, this is what happens. So one would really think, why would obesity and inflammatory bowel disease go together? As I said, the impaired linear growth or the height problem is almost seen in 1/3 of children. If it's a prepubertal, if the Crohn's disease hits the child before puberty, there's very high chance that this child will not grow very well, and very high chance of growth failure. If it's post-puberty, then I think usually the height is already attained, so it's not a major problem. In children with ulcerative colitis, impaired linear growth is much, much less common because it only affects the colon and not the small intestine. So now we try to connect the dots. I talked to you about the obesity, the high prevalence, the GI disorders, and now we looked at the inflammatory bowel disease, how it's diagnosed, how it's therapy causes therapy, different therapies, and now we're looking at the connecting the dots together. So first we'll look at the prevalence, and I'm going to show you different studies about how people have tried to look at it, how it is. Somewhat similar to, we have done smaller studies in children, but many of these children in studies are in adults, how the people have looked into that. So Dr. Moran looked at the 40 studies from all over the world, which they talked about the inflammatory bowel disease prevalence, and where there was a mention of weight and BMI. And he looked at from 1991 to 2008, over 18 years. And there were 10,000 adults with IBD, and he noticed that there was a significant increase in weight and BMI at the time of diagnosis. So if in 1991, for example, our average patient's BMI was 25, so in 2008 he noticed that the BMI was going towards more 28, 29, that kind of thing. So there was definitely increase in weight and BMI. They also noticed that the Crohn's disease activity increased, and they suggested that the adiposity, the fat, is increasing the intestinal inflammation in these patients. There was this nice European prospective nutrition study where they tried to address this question differently. They have been following these patients for a long time. They have their weight, height, BMI, and they've been following this over time. So they know which of these patients are obese, which of these are not obese, and their lifestyle, etc. And they had a very good monitoring follow-up. And over time, they found that 177 patients developed UC and 75 Crohn's disease in this cohort of patients where they're being followed up. They did a case control match to see whether the obese patients are more likely to develop ulcerative colitis or Crohn's as opposed to normal weight. And they did not find any association between higher BMI and the development of IBD. Having said that, then immediately there was another different study, the US Nurses Health Study, which is a very famous study. It follows more than 100,000 United States nurses, and they collect the data on regular basis, and they're followed very, very closely. And this study has given us a lot of very useful health information about different aspects of healthcare, because this is a large cohort which is followed on regular basis. In this study, they looked at 111,000 women where they had baseline weight and BMI, and they had much higher percentage of IBD diagnosis, 153 Crohn's disease and 229 UC diagnosed over 18 years. And they obviously compared this obesity versus control. And they found that if the nurse was obese, there's a chance of twice, 2.23 times that the person will develop Crohn's disease as opposed to not being obese. And they did not find any significant relation with ulcerative colitis. What about children? This was a multi-center study from North America. One of my friends did this study. They looked at 783 newly diagnosed children with IBD. And they found that 10% of Crohn's disease and 30% of UC children were obese or overweight. So that was pretty significant, that 30%, again 1 in 3, it's almost same as general population, that these children had ulcerative colitis, but they still were obese. And as opposed to that, the low BMI was seen in 24% of Crohn's and 9% of UC. So as you can see, it's happening sort of similar like celiac. So we always expect that the underweight children are the ones who might have the IBD, but that's not true. Even you can have overweight and you can still have the IBD. Another way of, another network, Improve Care Now network, looked at this with 1,500 children with new IBD diagnosis. And they again came up with sort of similar numbers. 20% of Crohn's and 30% of ulcerative colitis children were obese. So this was again, like as I said, it drives the point home that even if child is obese, it does not mean child does not have celiac disease or inflammatory bowel disease. They found that African American children are more likely to be obese, and obesity is associated with the need for surgery. What is the potential mechanism for this, if there is an association? So first simple thing is to assume that we saw, and I showed it to you, that there is a rising prevalence of obesity in general population throughout the world. And it's just possible that it's because of that the IBD also gets more patients of IBD are obese. But then there are suggested other mechanisms like microbiome, cytokines, steroids. And as you know, as you had mentioned, that microbiome is really hot topic, and people think every answer lies in microbiome, which I have my reservations about. But people have looked at that. There have been nice microbiome studies which say that preliminary studies suggest some association, that IBD has a fairly distinct microbiome signature. But when they looked at the obese people, they did not have such a great specific microbiome signature. So it's been difficult to compare, although there have been some preliminary studies showing association, and that might be the answer, although I feel it's more probably nutritional. Then there's the cytokines. We know that when you have inflammatory bowel disease, there are a lot of cytokines in the circulation, like inflammatory markers. And we know that obesity is associated with adipocytes. We also know that there's a lot of creeping fat seen in the Crohn's disease. When surgeons do laparoscopy or laparotomy, we see that there's a lot of creeping fat. So it's possible that these fat cells, adipocytes, secrete pro-inflammatory cytokines, and these can increase the intestinal inflammation and intestinal permeability. And this was Dr. Khalili, who did the US Nurses Health Study, suggested that this might be the cause that's predisposing these people to have inflammatory bowel disease. Now the most important, what's the clinical significance? And people have started looking at this more carefully in the last few years. The effect of obesity on IBD, there have been studies in adults and children. What people usually do design this study is that they compare obese versus normal weight patients, and they look at the outcome, like complications, need for therapy, like specific, like need for biologic therapy, need for surgery, and that's how then they finish the study and report the outcome, that obese people need more of this or they do not need more of this. However, at this stage we are really getting conflicting results, and in the next few years probably we'll get a real better answer. So this was a large, first most of these studies are adults. This is a large retrospective study from Paris where they looked at all their patients, more than 2,000 patients of Crohn's disease. And in retrospectively they divided them into obese and non-obese. The problem with this is that they only have 62 obese patients here and not many obese patients. And they found that the complication treatment over time for many years, and they found that obese people are more likely to have perianal disease, and they also have more need for hospitalization as opposed to the control group. So they thought maybe there's something going on and these people don't do as well. Another study from Chicago looking at the same problem but different way. So they look at the IBD patients who are undergoing laparoscopic surgery, either for colectomy, bowel resection, or for whatever, and then they decide, let's look whether obesity is a complication, causes more complication, or it's a risk factor. So they looked at overweight and obesity and normal weight and looked at these parameters. So during surgery, the blood loss was more common in obese people, operation time was more common in obese people, and the conversion rate, so the fact that they had to convert from laparoscopic to open surgery, was much higher in overweight people and slightly higher risk of hernia. So they declared that if you're going to do laparoscopic surgery in IBD and if the patient is obese, we're going to have a problem. Another small study in Seattle, but they looked at specifically about infliximab. As I said, we use infliximab biologic for severe disease, and the need to use that indicates kind of severity of disease. So they looked at that and they said that obese patients are more likely to have flare than non-obese patients. So they are more likely to fall sick. They are also more likely to have loss of response to infliximab than non-obese patients. Then again, as you know, this is what happens in the literature. Initially, there's always conflicting studies. People look at one way, people look at other way, and there are little difference in the studies, but comes with the conflicting results. This was done in Pittsburgh, where they looked at 391 surgeries, both laparoscopic and open, and they divided people into four groups: obese, overweight, normal, and underweight. And they found that op time, blood loss, intraoperative and 30-day post complications were not higher in obese patient, and they thought obesity is not a risk factor for surgery. So again, little different way of looking at the similar issue. This was from Dallas VA Hospital. They looked at, again, 581 patients. 1/3 of them were obese and 67% non-obese. And they found that obesity patients are less likely to need biologic therapy, hospitalization, or surgery. In fact, they thought maybe obesity is associated with less severe disease, which was a little bit surprising. In another study, 1,400 patients with IBD, they thought the obesity was not related to ER visits, hospitalization, or surgeries, but more importantly, it was related with diabetes, hypertension, and hyperlipidemia. So let's not forget that even if obesity may or may not have effect on IBD, obesity is a big health hazard with diabetes, hypertension, and hyperlipidemia. There's only one study in the kids, and we are looking at this ourselves at with our patient population. This was a kids inpatient database, and they look at the IBD related hospitalization. In this, unfortunately, there was a small group of children who were obese, only 2%. So this was a really small sample, but at least they concluded that obesity was not related to incidence of hemorrhage, perforation, fistula, or need for surgery, but did have central line complications. So what do we do when we see, because in our population, we have estimated we have almost 20% of children who are obese who are getting our treatment in our center. We look at monitoring of other obesity related complications like diabetes, hypertension, hyperlipidemia. We have a nutritional counseling. We definitely want them to lose weight, so we limit the caloric intake, but at the same time we have to have a nutritious diet, because many IBD patients lack into vitamins, B, D, etc., and we need to supplement that, and we encourage the physical activity. So in summary, obesity is associated with gastrointestinal disorders in children. I've shown some of our studies for you for that. Important thing is obesity is present at the diagnosis of IBD. Many of our pediatricians who refer to us initially were not referring because they thought child is obese, so unlikely to have IBD. That's definitely not true. The effect of obesity on IBD is unclear at present, but when we see this together, we definitely do nutritional counseling and weight management. And this is Yale University, and thank you for your attention. I'm happy to answer any question now or in the coffee break or any time. Yes, ma'am.
Are you still using the BMI classification of obesity, the class 1 if it is 30?
That's usually more.
And morbid obesity?
We are not using that. That's usually used in adults. You're absolutely right. So what we use as a grading of obesity is usually depends on the z-square. So we calculate, because you see BMI 30, if it's in the 5-year-old, it's huge. But if BMI 30 is 19-year-old, it's probably not. So using one number of BMI for kids is not a good idea, because their BMI changes. So that's what usually used in adults, but not in the kids.